Oh, okay. So dia buat macam mana? Dia buat case discussion.
Kalau dengan satu hari tu kita buat case presentation.
Oh,
Terus
okay.
ada ethical discuss. Lepas tu tadi dengan Dr. Alwi kita buat clerking.
Okay, alright. So what I'm dengan Alwi buat case apa?
Tadi denggi dengan respiratory punya
Bronchiolitis.
bronchiolitis.
Okay, alright, fine, good. So what we're going to do, I don't know how Alwi did it, but what I'll do is probably around the same as what Alwi did lah. Okay, so I'm going to give a basic complaint. Then we'll go one by one. What I want from you all is, what are the information that you want in terms of history? And then we'll go another round with information that you want by physical examination. Okay, all right. So basically, what we want to do is we want to look back at how for us to actually get information by clerking and by organizing the thoughts and information. Okay, boleh. I prefer to do case presentation because I think when doing case presentation, it is more useful for next time when you start working and so on and so forth. But I think because you guys won't be having the typical long case presentation, so I think that is the reason why the approach is a bit different. Okay, all right, let's go. Okay, so the basic problem is you have a child here who's presenting with facial puffiness. So, okay, how would you approach it? What are the informations that you would want to know in terms of history? Okay, we start with just history first. Okay, we'll go one by one. From my screen, the first one will be Izzati Amira, and then will be Ifat Azaim, and then will be Nur Aida Akilah, lepas tu Fawaz Naim, lepas tu Nur Akilah Ismail, followed by Sharifah Hajar, then Nur Hidayah, Daniel Nazri, and then Rauda Ruzairi. Okay, alright, boleh? Fine, let's start. Izzati Amira, say, what are the information that you would want to know?
Okay, regarding the facial puffiness, what the duration of the symptoms appear to the child?
Again, sorry.
The duration when the facial puffiness start.
The facial puffiness has been progressive for the past 5 days.
5 days, okay. So.
Okay, all right. Wait, next. Ifat.
I want to ask if there is any site that have pain.
Pain? There's no pain anywhere. Why are you asking about pain? Why? There must be a reason why.
Because I somehow suspect nephrotic disease problem.
Nephrotic. So why pain?
Nephritis.
So why pain? Kalau nephritis, why pain?
Because due to vasculitis punya problem.
Which vasculitis cause pain? Which vasculitis are you thinking about?
I don't know.
Any type of vasculitis that you know?
I don't know the name.
Okay. All right. I'm not saying you are wrong. Yes, there are some vasculitis that can cause nephrotic and nephritic as well. For example, is HSP, henoxone line purpura. It's a type of vasculitis. Yes, it can present with nephrotic syndrome and nephritis as well. But the main feature of those vasculitis are not joint pain. Can HSP present with joint pain? Yes. But is that their main presentation? No.
No.
The main presentation will be rash.
Oh.
Skin rash, purpuric rash. Okay, alright. Nur Aida Akila.
I would like to add the side, maybe side.
Side of what?
The side of puffiness and the most prominent part.
Okay, the complaint is already facial puffiness. Which part? So you're asking which part of the face that is most puffy? Is that?
Most prominent, yeah.
Okay,
if
okay,
not,
wait. Aida, let me ask you.
yes.
In your face, if it is
Mhm.
puffy, where do you think
Yeah.
it can get puffy?
Around all part of the
Yelah,
face.
semua. Tapi kat mana yang akan nampak
Uh,
mula-mula dulu? Kat mana? Logically, kat mana?
Mata.
Periorbital. Kenapa
Yeah.
periorbital? Kenapa periorbital? Why periorbital?
I don't know.
Okay, feel your face ni. Cuba tekan muka ni. You boleh teka tak kenapa kat periorbital ni yang paling, kalau bengkak, yang situ yang akan most prominent. Sini, there's not much bone here. Ada banyak. Lagi kembung kau, lagi macam-macam benda ada kat sini kan. So even if it is puffy, you won't notice that much. Dia akan lambat, you akan rasa. Kat bawah ni lagi, sini semua kan. Dia akan lambat rasa. Hidung, kalau dia puffy pun, lambat. Dia ada banyak soft tissue kat situ. Dahi, there's not much tissue kat sini pun untuk jadi edematous. Yes, it can be. Tapi tak. Mata ni, obviously because it's already sunken. It's already a bit sunken. Mata semua orang is a bit, kalau ke depan tu dia akan jadi exophthalmos. So it's a bit sunken. Kan? If you draw the face pun, mata pun this periorbital region ni akan macam sunken sikit. So even if you sleep too long pun, you akan nampak macam periorbitally nampak puffy sikit. Well, so what I'm trying to say is, your question is not right. Because it is facial. So when it is face, walaupun tempat lain yang more edematous pun, you will see first most prominent over the eyes. Because it is your face. Faham tak? Dia tak ada, there's no such thing as cheek puffiness. Tak ada. It doesn't start on your chin. It always appears most prominent dekat eyes dulu. Because it's just how your face looks like. Okay. Alright.
Okay, thank you, Doctor.
Tukar soalan lain. I'm not letting you go. I want a good question from you.
Maybe
I want a good question from everyone.
Maybe the time. Which I mean in the morning or night make it which is worse.
That is an excellent question. What are you thinking about? So tell us what line are you thinking?
Because it is a nephrotic syndrome. It is worse on waking. As
compared to?
I think. As compared to? Beda edema. I don't know. I'm not sure.
Sudah.
I don't know.
So edema because of heart failure, edema
Oh,
because of nephrotic
liver
syndrome,
disease.
because of nephrotic
Okay,
syndrome.
okay.
Usually they are worse in the morning, and then the moment you walk, the moment you everything, it starts to reduce.
Okay.
It starts to reduce a bit. And but certain diseases, they appear more when you walk more, for example. Yeah. Okay. All right. Fine. Fawaz.
There are edema at other sides of the body, especially in the ankles or the legs.
Oh yes. Baru mak bagi tahu. Okay, so the leg is puffy as well. Even the abdomen looks a bit distended as more than usual. Hmm. Okay, good question. Akilah.
I want to know whether um, the patient has the edema actually appeared gradually or like suddenly. Because if it's sudden, then it could be because of allergic reaction. If it's gradual, then it could be a nephrotic syndrome.
Okay, good, good. Okay, so it appears gradually. It's worsening by day. It's already 5 days. The moment you clock this patient, it's already 5 days. On day of admission, it's 5 days, and it's gradually worsening. Okay, all right, fine, good, good. It is very important to rule out things like allergic anaphylaxis and so on and so forth. Okay, all right, Sharifah Hajar.
Does the patient has fever?
No, no prior history of fever.
Okay.
Why? What are they thinking?
I was thinking about the infection, or maybe the post streptococcus pulmononephritis also can fever because of the infection, sore throat infection.
Okay, all right, there's no fever. Okay, Nur Hidayah.
Is the patient have any allergy because facial puffiness can be can be due to allergy reaction.
Okay, there's no known allergen. The child has not been allergic to anything. Okay, Daniel.
For this patient, may I know what is the age of the patient?
The age is 3 years old.
And aside from that, my second question is, does the patient urinate normally? I mean, how many times the patient urinate?
What are you trying to elicit?
Because in nephrotic syndrome patient, the patient might urinate less frequently than a normal kid.
Are you sure?
Tak.
Yang reduce urine output, which is oliguria, is it nephrotic or nephritic? Sudah. You started really well.
In
Yes, you need to ask about reduced urination and things, but you need to know why. So okay. Let me rephrase your question. Let me try and show you how we should ask the question. Okay. When you need, do you need to ask about urination? Yes, you must ask about urination. If you have this for your modified long case and you do not ask about urine, you should fail. You should fail if you do not ask about urine. So you need to ask few components. First, what is the normal frequency of urination? Because everyone has different frequency of urination. Some people, they need to pass urine every 3 hours. Some people every 4 hours. Some people only pass urine twice per day. Some people 3 times per day. It's up to different individuals. And many people have different volume to their urine. Depends on their bladder volume as well. It depends on their habit. It depends on their upbringing. It depends on the availability and so on and so forth. It depends on their activities of the day. It depends on their diet for the day. So there's so many factors. So the first question you should ask is, okay, you need to ask whether is there any change in terms of frequency beginning of the illness and as compared to before. Is there any change to the frequency of the urination? Is there any increase in frequency or reduced frequency? And frequency alone is not enough. You need to ask about volume. Sebab sometimes, for example, in a child with urinary tract infection, the child may have increased frequency, but the volume remains the same. A child with diabetes insipidus, for example, the volume increases and so does the frequency. A child with diabetes mellitus, the frequency may increase and the volume increases as well. Kan? So you need to know why. Kan? So a child with reduced urine output, is it because of obstructive uropathy? Is it because of renal impairment? What is the cause? So you need to ask whether there's any change in frequency and change in volume. Not just that, you need to ask also about the change in color. Because if there is blood in the urine, for example, your diagnosis should be different. Is it is it turbid? What is the color of the if the urine is turbid? Then probably there is some infection going on. Is it clear? Is it becoming more clearer? Is it more dehydrated? The color is more dehydrated. The more thick color, more orange, more pronounced color. It may be dehydrated, maybe dehydrated for some sort. And the quality of the urine as well. What do I mean by the quality? Is there any is the urine frothy? Kalau frothy urine, berbuih-buih, what are we thinking about?
Nephrotic.
Nephrotic syndrome. Kenapa nephrotic jadi frothy urine?
Proteinuria.
Because of protein.
Because of
Yes.
protein.
Yes, true. Okay. All right. So those are the questions you need to ask about urine. Okay. 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 Right. Next. Rauda.
I would like to ask about if this patient have trouble breathing.
Trouble breathing. What are you thinking?
Heart failure.
Heart failure. Okay. How would you formulate that question if you were to ask the parent? How would you ask that question?
If this patient you said she is 3 years old, right?
Yes.
If she feeling tired after playing with friends, or after waking up.
Is it abnormal for someone to feel tired after playing?
Early tired, and maybe.
So
How about climbing stairs?
is it not normal for is it not normal for someone to feel tired after climbing stairs?
Normal.
Normal kan? You all pun satu tingkat pun naik lift kan? Hmm. So normal or not normal?
Normal.
So how do you know it is abnormal then?
When lying down.
Tired when lying down.
I mean, breathlessness.
Breathlessness when lying. Okay, fine. Let me help you to rephrase the question. Okay. Okay, you remember what I said when Daniel was giving his question about urine. It's always about comparison. It's always about comparison. So your question, there should be two elements. First, tiredness. Yes, you need to ask about being tired. But tired does not necessarily mean breathless. Breathless and tired are two different things. And you need to assess both. So again, you need to compare. How to compare? You compare between before the illness and during the illness. You can ask the mother, is there when the problem begins, does the child appear easily, the child get tired easily as compared to before? Like previously, he can climb few flights of stairs. Currently, he can't even climb any stair. Previously, he used to play with his friend. Now, even trying to get to his friend, he becomes breathless. He becomes tired. So those are questions you need to ask. Faham tak? So rather than campaknya tu, you kena compare tired and breathless. Kalau mak kata ada, oh no, this child is becoming more breathless as compared to before. Then you need to ask, then what are the activities that, what is his limit now? Kan? Maknanya dia boleh climb berapa flight of stairs. Dulu boleh climb berapa flight of stairs. Tapi tak semua rumah orang ada stairs. Kan? Tak ramai orang yang ada stairs. Kan? You duduk hostel mungkin ada stairs lah. But not all houses have stairs. My house don't have any stairs. Kan? So you cannot assess climbing flights of stairs. But probably you can ask about distance. Kalau jalan daripada pintu depan sampai ke dapur, does he get tired? Does he get breathless with that? And with that also you can ask about daily activity. Is there any reduction in his daily activity? He used to be a very bright and cheerful, playful child. Now he's becoming very lethargic, just lying at home. Okay, alright. Nampak? Tahu tak?
Nampak.
Boleh tanya. Okay, alright. Let's go one last round. Izati.
Yes, doctor. Question.
Okay, Ifat. Cepat. Lepas tu Aida Akilah.
Tak tahu lah. Dah ditanya tadi.
Habis dah? Tak ada soalan dah? Aida Akilah.
I would like to ask about URTI symptoms such as runny nose or sneezing.
Okay, good. What are you thinking?
Because for this patient, suspected he had the patient has nephrotic syndrome. So it means that the glomerulus is having damage. So immunoglobulins, just like all the antibodies or protein will lost through the urine. So that's what I'm taking, the complication of the nephrotic syndrome. So,
not really ya. Tak berapa bagus ni. Soalan dah menarik dah. Tapi the reasoning behind the soalan tu, it's not really sound. Okay, tak apa. Fine, we are not going to discuss that. Okay, Fawaz.
Are there any cutaneous lesion or any joint pain?
Okay, what are you thinking?
It could be lupus nephritis.
Lupus nephritis. Okay, alright, fine. Did you do you know what is the gender of the patient?
Female.
Did I say female?
Oh, tak.
No one asked yet about gender of the child. So if it is lupus nephritis, Usually, which gender is it?
Female.
Female. So all these connective tissue diseases are more common in female.
So is this patient male then?
Yes.
Okay.
Well, let me answer this. Yeah. Okay. All right. What was the question again? Is there any what?
The cutaneous lesion
Cutaneous
or
rash. Okay, so there's no rash. There's no rash. There's no cutaneous lesion. Okay. All right. Akilah Ismail. You the one that contacted me ke?
No. it's
Bukan?
not
Siapa yang
me,
contact?
bukan.
Ifat saja.
Yeah. Oh, okay. All right. Fine. Akilah, cepat. Yes.
Okay, I want to know whether the patient has any purulent nasal discharge or any ear discharge,
Why?
because I want to know whether if the patient has sinusitis or infection, the signs of infection.
Why?
Why?
Hmm.
Because those kind of patient can present with facial edema also.
Sinusitis causes facial edema.
Yes.
How? Why?
Like inflammation of the sinus.
So facial swelling or facial edema? Facial swelling,
Oh,
facial edema is just edema. It's edema. Facial swelling can be due to inflammation, can be due to edema, can be due to so many things. If you are thinking of okay, fine. And then you remember the other problem with the what have we discussed? What are the symptoms that the patient has? We know the patient is 3 years old. We know the patient is boy. We know the patient has we didn't discuss about urine output. The question was there's no change in urine output. It's a bit frothy. Urine is a bit frothy. There's no fever. There's no UTI symptoms. And the edema is all over, meaning there's ascites, there's abdominal distension, there is ankle edema as well. So should you be thinking about sinusitis, mastoiditis?
less likely.
Less likely. Okay, all right, fine. Sharifah Hajar.
How about the diarrhea? That's
Diarrhea. Why? There's no diarrhea, but why? Why are you asking those questions?
um, maybe because nephrotic syndrome.
Nephrotic syndrome typically presents with diarrhea.
Not
But yes. But what? Huh?
And associated symptom.
Diarrhea. Why diarrhea?
I'm not sure. Maybe because of the proteinuria. I'm not sure.
Any bowel symptoms specific to nephrotic syndrome, complication of nephrotic syndrome, bowel. Gana ni.
I'm not sure.
Spontaneous bacterial peritonitis. So, spontaneous bacterial peritonitis is a known complication of nephrotic syndrome. So if it is peritonitis, what are the symptoms you should have asked?
Abdominal pain.
Abdominal pain, yes. Fine. Okay, Nurul Hidayah.
Okay, we can ask whether the child express irritability
Why? What are you thinking?
because maybe the child um the child uh, mm,
Why? What are you thinking?
maybe uh uh
Because
maybe that
when you ask question, you need to have reason.
maybe they tak selera makan ke
Tak selera makan. Apa ni? You're asking about irritability. Kenapa? Apa kaitan irritability yang tak selera makan ni? What are you thinking? What is your
yeah,
diagnosis? What is the diagnosis that you're thinking?
nephrotic syndrome.
So nephrotic
Maybe
irritable nephrotic syndrome. Okay lah, fine. Daniel Nazri.
I want to ask if the patient have any siblings, any other siblings.
Tak berapa menarik soalan tu. So the question should not be does the patient has any other sibling. The question should be the patient is anak keberapa daripada berapa adik-beradik. Faham? Macam tu. So maknanya the patient is which number out of how many siblings. That would be a better question.
Okay.
Why do you ask that question?
Kalau if the patient already have brother or sister, I want to know if his sibling have the same kind of symptoms before this.
Okay, so then your question is totally wrong lah. So you should have asked, is there anyone in the family with similar symptoms? Not just in the family. You should have asked, is there anyone in his contact that has similar symptoms? So sometimes memang dia duduk dengan family dia, kan? Dia duduk family tapi dia mungkin dia tak duduk dengan sibling dia. Because if you are siblings, it does not mean you are living in the same house. Kan? Sometimes sibling tapi duduk rumah lain. Sibling duduk dekat rumah grandparents ke, ataupun ada pengasuh yang jaga dan sebagainya. Kan? So konteks ni yang penting. Ada tak orang yang dia ada jumpa yang ada similar symptoms?
Okay.
What are you thinking? What disease are you thinking?
Actually, it's not not infectious disease. I just want to conclude that if the nephrotic syndrome runs in the family.
Okay. Can you name me one disease? If I were to tell you, he has another brother with similar problem before, and now is on dialysis. Name me one disease. Anyone has any idea? Male, nephropathy, nephrotic syndrome, renal failure.
Kidney failure.
Huh?
Kidney failure.
Memanglah kidney failure. I'm asking about the disease. Kidney failure tu is the thing. Tapi what is the name of the disease? There's a name with the person's name. Alport syndrome. Alport. Google lah nanti Okay, fine. Rauda Ruzairi. So in that sense, Daniel punya soalan is actually good. So but the question should not be jadi adik-beradik tak. The question should be, is there any other family member with the same problem? Okay, alright, Rauda.
I would like to ask if this patient about past medical history, if she has been diagnosed with other medical history.
Yes, okay, that's a good question. But a better question should be, does the child has any other illness before? Was the child ever been admitted before? So those are better questions. Okay, all right. So we've been asking question for 37 minutes exactly. What is the provisional diagnosis so far? And what are your differential diagnosis so far, just from history? Again, I would want medical students year 3, you should have at least 5 differential diagnoses. You need to have one provisional diagnosis because you manage patients based on your provisional diagnosis, but you need to have at least 5 differential diagnoses. Okay, all right. Let's ask this first, and then we go to physical examination. Okay, Izzati, provisional and differential.
Provisional diagnosis.
Orang lain fikir.
Nephrotic syndrome. It can.
Okay.
Yeah, even okay. So
Why?
for
Why nephrotic syndrome?
Because the patient have facial puffiness, and also ankle edema, ascites, signs of
So
presentation.
generalized edema or
Yes.
anasarca. Okay, all right, fine.
Yes. And
Differential?
Differential, acute post streptococcal glomerulonephritis.
Okay. Why? Why and why not?
Why? It may be due to the edema also, but it may not because there's no fever or any past infection, past history of infection to.
If you are thinking of AGN, what would be the other important history?
Important history.
Hematuria, hematuria, hematuria.
Hematuria. Oh, okay. Hematuria. Yes.
Okay, alright, alright. Okay, kita apa? Kita kawan yang pula. Ifat. Provisional and differential. I expect 5 differential.
My my provisional, so the same like Izati actually. Due to the presence of facial.
No. I don't accept you saying it's the same. Tell me what it is. I don't care if I don't care if everyone mentioned the same thing, but I don't want to hear same as before. You tell me what it is.
My professional analysis is nephrotic syndrome.
Yep. Why?
Presence of facial puffiness, leg edema, and due to the urine, quality of the urine, for the urine.
Okay. All right. Differential.
If my differential is post streptococcal glomerulonephritis, but and due to the presence of facial puffiness, also leg edema. However, there's no presence of other illness from this patient, like past infection Also, there is no fever. And then, yes, I guess that's all.
Okay.
That's
All
all I can.
right. Fine. Next. Aida Akila.
For the provisional diagnosis, I will choose nephrotic syndrome also
Okay.
because of the facial puffiness and ascites. Ascites.
This is your mic. Your mic ke my mic yang bunyi?
My mic.
Huh?
My mic maybe.
Your mic.
I think my mic. Maybe my mic is problem.
Mic beli kat DIY. Okay. Alright.
But can you hear me?
Can, tapi it's too much noise.
Oh yeah. Sorry. I try.
Okay lah, tak apa. Next, Fawaz. Kita pergi kat Fawaz. Nanti kita patah balik kat Aida.
Huh?
Okay. Dengar sikit.
For the nephrotic syndrome because of facial puffiness, and there is also peritonitis, right?
There's no peritonitis, no abdominal pain.
Okay. The proteinuria,
Okay. Alright. Fine.
and then
Ada differential.
maybe I will choose allergy.
Okay.
Because
Why
of
and why not?
facial puff. Huh?
Why and why not?
Why? Because allergy also can come with facial puffiness around the eyes, swelling of the eyes, and yeah, like that. And there is no. I think that's the positive point for the allergy.
Okay. Ada differential?
And next, I think also for post-streptococcal glomerulonephritis, PSGN.
Okay.
Because of edema also around the eye. Proteinuria.
Okay.
And I think that's all. I'm not sure.
Okay. Tak cukup nak ada 5 differential. Okay, Fawaz.
My provisional diagnosis is nephrotic syndrome because the patient has facial puffiness, ascites, leg edema, and also frothy urine. My differential diagnosis would be it can be heart failure because it has edema, but the patient doesn't have dyspnea or any underlying congenital heart disease. The patient can also have post-strep glomerulonephritis because edema and also frothy urine, but I'm not sure if the patient has hematuria or not, and also because the patient doesn't have previous infection. Lupus nephritis may also occur because the patient has edema and frothy urine, but like earlier said, SLE is usually occur in female patient instead of male.
Okay, right.
Allergic reaction can also occur because the patient has facial puffiness, but the patient doesn't have history of any allergies. And acute renal injury because facial puffiness, but the patient doesn't have there's no urine output change in the patient.
Okay, alright. Next. Siapa dah? Nur Akila Ismail.
Yes, my provisional diagnosis would be nephrotic syndrome as well.
Okay.
Because of the facial edema And my differential diagnosis would be post-streptococcal glomerulonephritis, but again, the patient does not present with hematuria. And other differential diagnosis would be like allergic reaction because of facial puffiness as well, and acute renal injury because of facial puffiness as well. But in acute renal injury, there is no reduced urine output. So okay, other differential diagnosis like heart failure could be congenital heart failure, but we have to it can cause facial edema as well, but we have to actually do a further examination. Yes, and
Okay, alright. Ada differential lagi? Lagi differential. Okay, tak apalah. Next, Sharifah Hajar.
So for my provisional diagnosis, also nephrotic syndrome.
Okay.
Okay. And differential diagnosis, post-streptococcus glomerulonephritis, allergy, and also I want to add one more differential diagnosis, which is hypothyroidism.
Okay.
But we don't ask much about the sign and symptom, like the cold intolerance, hair loss, and also the skin. Maybe we can ask more about the symptom of hypothyroidism.
Okay.
Thyroid.
Alright. Okay. What else?
Think that's
Okay, Nur Hidayah.
For my professional diagnosis, we can nephrotic syndrome because because of the facial puffiness and edema, and the patient have frothy urine, and the edema also worsen in the morning. So for my differential diagnosis, first allergy reaction because of the facial puffiness, but the patient have no allergy, have no non-allergy, and next lupus nephritis because the patient have edema and frothy urine, but the patient have no sign of SLE such as rash. And I want to add one differential diagnosis, chronic liver disease, because the patient have edema, but we did not ask furthermore regarding about this diagnosis, such as if the patient have jaundice or not. We no and we need to do the further physical examination to
What are you thinking again just now? What's the diagnosis?
chronic liver disease.
Liver, yes, very good. Finally, someone is thinking properly. Okay, excellent. Daniel.
For my provisional diagnosis, I would think it as a nephrotic syndrome, as the patient come with the edema and also frothy urine and ascites. And for my differential diagnosis, the first one would be PSGN as the patient have edema and proteinuria. But the points against PSGN is that there is no hematuria.
Okay.
Next is fluid overload secondary to the heart failure because the patient have edema and also ascites, but
Yeah.
there is no heart failure symptoms and no heart failure symptoms.
Can you enlighten us? What are the heart failure symptoms that you would want to know?
Orthopnea, shortness
Okay.
of breath,
Lagi?
shortness of breath,
Lagi?
and paroxysmal nocturnal dyspnea.
Okay. Lagi? One more?
Uh, Cardiomegaly.
That is physical finding. Can you get it from history?
No.
Okay. Lagi? Reduce effort tolerance.
Uh,
Okay. All right. Fine. Next, Rauda.
My provisional diagnosis will be nephrotic syndrome because of the presence of edema, facial puffiness, and then frothy urine. And my differential diagnosis first would be lupus nephritis because of the presence of edema and frothy urine, but there is no rashes, no signs of SLE. And then the next one is heart failure because of edema. But the patient does not have dyspnea. And then the next one would be acute renal injury because of the facial puffiness. However, there is no reduce in urine output. And I would like to add one more definition, that is kwashiorkor, protein malnutrition. However, we need more history to diagnose this patient and also physical examination for loss of muscle mass, failure to grow in height.
Okay. Fine. We should actually go towards go to physical examination. So I expect you to know. So I did say, isn't it? We'll go first about history and then we'll go to physical examination. So have you guys thought of what are the physical examination you would expect from this child? That you would want to know from this child. Have you thought about it? Dapat fikir dah? Izzati fikir dah? You have the one with the longest time to think.
Uh,
Dah fikir dah?
yeah. Yang positive findings ke tak?
Tak kisahlah. Whatever you want to know. Physical examination. Okay, wait. Now it's already 54 minutes. I'm not going to do teaching for a very long time because I don't like teaching a long time because I think after 1 hour, your brain will go into cerebral atrophy already. So especially online teaching. Online teaching, I think maximum is around 1 hour. It shouldn't be too long after 1 hour. It's not useful anymore. Okay, but the thing is, okay, when you clerk case or when you present case, because you clerk this patient, you get the information, you get the history, you do physical examination, and then you will present the case. As doctors, you will be presenting case your whole life. What is the purpose of presenting a case? Kenapa kita suruh you present? Kenapa kita suruh you buat case write up? Kenapa? Why? What are the objectives?
To find out the provisional diagnosis.
To get to your provisional diagnosis, because you manage the patient based on your provisional diagnosis. The management will depend on your provisional diagnosis. Your investigation will depend on your provisional diagnosis. How you treat, how you go about with the patient, how you treat acutely depends on the provisional diagnosis. What are the second objective? The first is get to your provisional diagnosis. Second is to
rule out the
rule out the differential diagnosis. Because as doctors, we need to think, are we missing something? Not just on admission, we need to think about other differential diagnosis every time, each time we review the patient. Because we may be missing something. Because we work for the best of the patient. Are we missing something? Is the diagnosis actually something else? Sometimes if the treatment is not really working, it's too slow, probably we are missing something. Probably the disease is something else. So what are the differential diagnoses? We always think about differential diagnosis. So because I've seen people on admission diagnose lain, so treatment pun lain. The moment we broaden our mind, the moment we broaden our history and physical examination, the moment we think more robustly, then we can get, oh, diagnosis is actually different. And when you change the diagnosis, the management differs as well. The prognosis differs. Complications maybe differs. So everything will change when you change your diagnosis. That is why you need to always think, what are the differential diagnoses? And at least I want 5. Your level, you should have told me 5 differential diagnoses. Minimum 5. Because you can only ask appropriate questions when you know what is the provisional and what are the differential diagnosis. Baru you boleh tanya soalan yang positif dan soalan yang negatif. Baru you tahu what are the checklist that you need to ask. What are the information you need to get. And what are the information you need to get to actually confirm your provisional analysis and rule out your differential diagnosis. And you need at least 5 differential for you to rule out. Okay. Alright. Third objective. First, get to your provisional diagnosis. Second, rule out differential diagnosis. Third, what is the third objective?
To look for the complication from the physical
To look
examination and history.
for complications of the disease, because all disease has complication. Nothing in this world doesn't have any complication. Everything in this world have complication. Everything, every disease has complication. Nephrotic syndrome has complication. GN has complication. Liver disease has complication. Heart failure has complication. Everything in this world has complications. So in your history, in your physical examination, you should look for all those complications. Okay. All right. What is the fourth objective?
Management.
To look for the complications of treatment. Because something must have been done to the patient. This patient admitted day 5 of illness. Do you think mother will do nothing for the past 5 days? Mother definitely has done something. 5 days. Mesti dia buat something. Apa mother dia buat? And whatever we do has its own complication. Not doing anything pun ada complication. Tak buat benda pun ada complication. Buat benda lagi ada complication. Also, if you clerk, when do you clerk and examine this patient? Do you examine on day of admission, at admission, or you clerk few days after admission? If you clerk at emergency department, for example, pukul 2-3 pagi, tengah kelang-kelang kabut, sometimes you may not get full information. If you compare to when you clerk the patient after 3 or 4 days of admission, so many doctors have asked the parents the same question. So parents already know what are the questions that doctors want. What are the questions that medical student wants. So dia tahu dah. Certain parents dah siap tulis dah jawapan dekat atas kertas. Bagi dia, doktor ni semua jawapan kepada soalan-soalan. Kan? Kan? And then parents pula sometimes, especially fathers lah, they don't remember things. They remember football, dia ingat. Biasa football lah. Lain pada tu dia tak ingat sangat. Kan? Yang lain semua, mother kena jawab. Tanya dia. Kan? So sometimes bila tanya mula-mula tu parents don't remember. Tapi after few days, parents can recall sebab doktor tanya, dia pun recall, dia pun check, oh ada benda ni, dia tak ingat, dia call orang yang ada kat rumah. Apa dulu macam ni? So they get more information. So if you clerk later, then you'll get more history. So should you not clerk at the beginning? Yes, you clerk the patient every day. That is why you need to ask patient every day because you may get different information. Kan? So when you clerk the patient. So kalau you clerk dah after 5 days of admission, for example, some treatment may have been done. And those treatment may have complication. For example, if you have you discussed earlier tadi kan dengan Dr. Alwi about bronchiolitis. Some mode of treatment may have been given. Kan? Dia bagi nebulization, for example. Nebulization has complication. Kan? Dia bagi certain treatment. Asma. You datang patient dengan asma. Dia bagi nebulization. Nebulization ada complication. What are the complications of nebulization? By the way. What are complications of salbutamol nebulization? Akilah Ismail. What are the complications of nebulization? Of salbutamol nebulization?
So I think wait. Dizziness.
Dizziness, not really. Sharifah Hajar.
Maybe dry mouth.
Dry mouth, more towards atropine or ipratropium rather than salbutamol. Ifat, we lost Ifat. Sebelum ni ada kamera. Di mana Ifat ni? Tidur. Ada. Okay, alright. Salbutamol.
Palpitation.
Palpitation, yes. Palpitation, tachycardia, tremors.
Anxiety.
If you do blood investigation, what can you find as a complication of salbutamol?
Increase blood pressure.
Increase blood pressure. Okay, why? Macam mana boleh increase blood pressure? Siapa jawab tadi? Daniel. Macam mana boleh increase blood pressure? Macam mana?
I don't know.
Tadi kita cakap tadi increase heart rate kan? Tachycardia. Any relation tak heart rate dengan blood pressure?
Yes.
Apa? Macam mana? Relation macam mana? You learn this just last year. Not last year, probably few months back je. What is blood pressure? Dia ada formula kan? Blood pressure equals to A times B. What is it?
Heart rate.
Blood pressure.
Cardiac.
Okay, yep. You're going somewhere. Ifat kan? BP equals to?
Heart rate dengan volume output.
Cardiac output. Siapa cakap tadi? Akilah. Cardiac output times apa?
Times heart rate.
Total peripheral resistance.
Cardiac output times total peripheral resistance. Yes. BP equals cardiac output times TPR. Yes. Understand this formula. Because nanti year 5, bila you belajar management, kan, you akan nampak ni, apa drugs yang affect cardiac output, apa drugs yang affect peripheral resistance. Okay. What is cardiac output? Ada formula dia untuk cardiac output kan?
Heart rate times stroke volume.
Yes, very good. Sharifah Hajar, excellent. So, cardiac output is stroke volume times heart rate. So, theoretically, bila you increase heart rate, the blood pressure may also increase. Okay, tu satu cara. Tapi biasa tak banyak sangat lah. Sebab bila you increase heart rate, Kalau BP dia jadi tinggi, body akan maintain dengan cara yang lain. Dia akan reducekan total peripheral resistance and so on and so forth. Okay, sebab your body doesn't like high blood pressure as well, kan? Okay, so if you do blood investigation, if I take blood from a patient that was given salbutamol, what can I see in terms of complication of salbutamol? Hypokalemia, potassium will be low. Okay, fine. So the point I'm trying to highlight here is there are 4 objectives. First is to get your provisional diagnosis, to confirm your provisional diagnosis, to focus on your provisional diagnosis. So your history should actually go and focus and zoom, confirm your provisional diagnosis. And it should look for all, not just your history, your physical examination as well. So everything from history, physical examination should actually focus, targeted towards your provisional diagnosis. It should rule out your differential diagnosis. At least 5 differential diagnosis you need to rule out at your level. Year 3, I expect 5. Year 5, I expect more. Kan? Your houseman, I expect more. Kan? You need to rule out. Look for all the positive and negatives of all differential diagnosis. You need to look for complications of the disease, because knowing the complication of disease is very important, and you need to look for all those complications. And look for complications of the treatment, because treatment may have been done and all treatment has its own complication. You bagi air kosong pun ada complication. You letak drip ada complication. You put IV lines ada complication. Everything you do there is complication. Tak buat apa-apa pun ada complication. Faham? So you need to look for all those complication. Clear? Faham? And these things, history and physical examination. Okay. Boleh? Alright, boleh. This already 1 hour 10 minutes. This is a bit longer than what I expected. Okay, fine. We're going to stop there for now. What I'm going to do next is, let's go to pathophysio. Because I always tell students, it's good if you know, if you can remember things, but it is better if you understand the pathophysiology. Because if you understand the pathophysiology, you understand how to manage. You understand the basis of the disease. It will help you. Okay. All right. Let's go through the pathophysiology of nephrotic syndrome. What is nephrotic syndrome? Okay. Where can you get all this information? Where? Izati, macam nak jawab something. Mana nak rujuk mana ni? All this information.
Kalau Google doktor, boleh.
Google should be your last answer lah. Your first answer should be
Books.
Nelson.
Okay,
Kan?
Nelson.
Okay, baca Nelson. Lepas tu kau tak baca buku Tom Lissauer tu kan, buku Sunflower tu. Medical student panggil buku Sunflower kan. Sampai sudah
Yes.
Sunflower. Tom Lissauer punya buku. Okay lah, alright lah. Ni semua basic-basic buku. People don't read textbook already anymore. Sekarang people should read journals kan. But at least at your level, at least you should read pediatric protocol. Pediatric protocol for Malaysian Hospital 4th edition. You should have PDF version of it. Read that cover to cover. At least minimum baca PID protocol. And you will get all this information. Okay. Alright. So you need to know how to diagnose nephrotic syndrome. What is nephrotic syndrome? Aida Akilah, what is nephrotic syndrome? Tell us. Nate gapo nephrotic syndrome?
Heavy proteinuria.
Huh?
Heavy proteinuria.
Okay.
Heavy
So
proteinuria.
massive proteinuria. You know the value?
More than 3.5 gram per 24 hours.
More than berapa? 3 salah tu.
3.5 salah.
Hmm. Okay, satu massive proteinuria. Next, apa lagi?
Edema.
Massive edema. Okay, alright, lagi? Kedua,
Hypoalbuminemia.
hypoalbuminemia. You know the number?
I'm not sure. Less
Okay.
than 5.
Ah,
Less than
Le-
2.5.
less than 25. So serum albumin less than 25 grams per liter. Kan? Lepas tu urine proteinuria dia adalah basically more than 40 milligram per meter squared per hour or more than 1 gram per meter squared per day. Per meter squared per BSA dia. Ataupun if you do early morning urine PCI, urine protein creatinine index, then you may get it as more than 3.5 milligram per milligram or more than 200 milligram per millimole. So that is nephrotic syndrome. Okay, what? Siapa nak tanya Fawaz, you want to try explain the pathophysiology of nephrotic syndrome? Dah belajar kan ni kan? Kan? Dah belajar kan?
Ada.
Ha. You guys should be better in pathophysiology than me Fat.
Nephrotic syndrome kan ada massive proteinuria. So
Okay.
bila ada massive proteinuria, albumin dalam blood kurang. So bila albumin kurang and protein pun hilang, plasma oncotic pressure reduce. So sebab oncotic pressure reduce, so fluid akan keluar from intravascular pergi extravascular. Betul.
Itu je.
Uh,
Anyone nak tambah? Daniel Nazri, ada benda nak tambah?
Pasal the changes of the endothelial cells.
Macam mana change macam mana?
Normally in the nephrotic syndrome, the glomerular basement membrane and the podocytes cannot filter the urine properly.
Okay, interesting. Okay, fine. Macam ni. So the basis problem in nephrotic syndrome. So nephrotic syndrome dia ada dua. Dia ada primary and secondary nephrotic syndrome. So primary nephrotic syndrome dia ada mainly is minimal change disease which accounts for 70 to 90% of all nephrotic syndrome. Second will be your messenger glomerulonephritis. Second will be your focal segmental glomerulosclerosis FSGS. And then secondary tu so many reason lah. Secondary tu post-strep GN, secondary tu SLE, secondary tu hepatitis, HIV, secondary tu HSV, secondary tu measles, chickenpox, secondary tu jengkol, makan jering jengkol nephropathy. Secondary to so many other problems as well. So that's secondary. So but mainly the problem is there is inflammation occurring near your glomerular basement membrane, and then there'll be it will affect mainly the podocyte and its food processes. So glomerular basement membrane ni dekat you punya dalam Bowman capsule connect to your proximal loop of Henle and then distal convoluting tubule and then collecting duct. Bowman capsule. Dalam Bowman capsule ni blood daripada efferent arteriole goes into your glomerulus. Pusing kat situ, then dia keluar ikut your afferent and then efferent arterioles. Dalam your glomerulus tu, dia ada your glomerular basement membrane kat luar dia. Luar pada glomerular basement membrane tu dia ada podocyte and dia punya food processes. Podocyte and its food processes. So apa GBM and also your podocyte and its food processor buat ni adalah dia filter out things. So benda-benda yang kecil boleh pass through, benda yang besar-besar tak boleh pass through. Benda macam protein, for example, cannot pass through. Albumin is a relatively large particle, cannot pass through. Blood cannot pass through. Small particle like electrolytes dia boleh pass through. So dia filter. Macam mana dia filter? Satu, between the podocyte food processors tu dia ada channel. So the channel is very small. So hanya benda yang kecil je boleh pass through. Dia ada channel, dia ada lubang dia, ada gate dia. Lepas tu pula, this channel are negatively charged. So bila dia negatively charged, particles yang negatively charged as well, macam albumin, they cannot pass through. Sebab apa? Sebab dia negatif juga. So bila dia negatif, they cannot pass through. So in nephrotic syndrome, what happens is few things. First is the podocyte food processors becomes effaced. Podocyte satu sel dia ada kaki. Sel ada kaki macam ketam tu. Kan? Dia ada kaki-kaki dia. So kaki dia become effaced. Lubang dia daripada mula besar ni jadi besar kangkang macam tu. Bila the channel tu is become bigger particle can pass through. Bigger particles such as albumin. Kalau besar lagi blood boleh pass through. Kan? So the first problem is effacement of the podocyte food processors. Nombor dua is the change in the ionicity of the food processors. Sebelum ni I told you is negatively charged. Sekarang ni dia bukanlah jadi positif. It just become less negative. Bila dia become less negative, benda yang negatif dah boleh dekat dengan dia. So it's now become less negative. Kalau dia jadi positif, dia pull dan dia tak lepas. Sekarang ni dia become less negative. So benda yang negatif pun boleh datang dekat dan boleh go away. That is why something yang negatively charged macam albumin can pass through. Okay, so this results in apa? Results in massive proteinuria because albumin is abundant and albumin can pass through the glomerulus into the ductal into the collecting system. My battery is already low. Okay, fine. So next, let me look for charger. Sorry, before my alright. Okay, so it results in proteinuria. So what is the result of massive proteinuria? Because of massive proteinuria results in hypoalbuminemia. So hypoalbuminemia as the value is less than 25 grams per liter. Okay. What is the result of hypoalbuminemia? So you know hypoalbuminemia affects the Starling forces. What you remember Starling forces? What is Starling law? Dari dua, Starling law, Starling force. Apa Starling law? Anyone remember what is Starling law? Starling law in your heart. Jantung. Apa Starling law kata? Cepat-cepat, penat ni. Syarifah Hajar. Starling law.
Is it because of the cardiac output, but I don't remember.
Okay, lebih kurang lah. So, Starling law kata, if you have more venous return, your what is the ventricular filling. If you have more ventricular filling, if the ventricle is filled more, it will have stronger contractility. Lagi banyak fluid dalam dia, dia akan pump harder. So this is what Starling law says. I change it to a more layman term lah, orang kampung macam saya kan. Okay, alright. So this is Starling law. How about Starling forces? What is Starling forces? Apa Starling forces? Ni, Rauda Ruzairi. What are Starling forces?
it's about passive exchange of water between capillary and interstitial fluid.
Okay, example.
Example, hydrostatic pressure in capillary, oncotic pressure.
Okay, so basically these are the forces that maintain the equilibrium in the equilibrium state in the intravascular and extravascular spaces. So upper forces yang affect all this equilibrium, so that the hydrostatic and also oncotic pressure, plasma intravascular hydrostatic and intravascular oncotic and also extravascular. Okay, so effacement of podocytes, change in ionicity of your podocyte food processes results in massive proteinuria. Massive proteinuria results in hypoalbuminemia. Hypoalbuminemia affects your Starling forces, reduces the intravascular oncotic pressure or plasma oncotic pressure. Relatively increases, it increases the intravascular hydrostatic pressure. So what happens then? Then there will be massive fluid shift from intravascular into extravascular space. Okay, from now on, there are dua theory. The underfill theory or the classical theory and the overfill theory. So underfill and overfill. What does underfill theory says? Underfill theory is the classic theory. So in underfill theory, there is massive fluid shift from intravascular to extravascular space to maintain the equilibrium between the hydrostatic and oncotic pressures. So what the net result is? Interstitial edema, third space loss, kan? So fluid is lost into your third space, results in massive edema, anasarca. So anasarca is massive edema, kan? Edema, ascites, pleural effusion, pericarditis, pericardial effusion. So all these are results of fluid shift into your third space. And also, what will happen to your intravascular volume? What will happen to your intravascular volume bila fluid shift daripada intravascular into your extravascular?
Reduce.
Intravascular volume will reduce. So it will be underfill. So what happen bila less volume, less fluid in your intravascular space? What will happen?
Release of aldosterone.
Sebelum lagi. So what happens bila jadi macam tu? Apa? Your body will be
Hypovolemic.
hypovolemic. Yes, you'll be hypovolemic. So ada cascade yang jadi bila hypovolemic kan, heart rate naik, BP factor and so on so forth. Okay, also bila hypovolemia will result in reduced renal perfusion. Your afferent arterioles tu reduce fluid. It will be detected by your reticulo by the there are some cell dekat your near the kidney nephron tu kan, and then they will activate your RAAS, renin angiotensin aldosterone system kan, and it will apa, dia akan cause more water retention. Dia akan cause water retention, salt and water retention. Not just RAAS, not just renin angiotensin aldosterone system, it will also affect your noradrenaline. It will also affect your you also activate noradrenaline, also will activate your Allah Rabbi. Now I can't remember. MashaAllah, I can't remember. There's another system that is activated as well. Can't remember.
Sympathetic, doctor.
No. So yes, sympathetic is part of the hypovolemic cascade, really, honestly. Okay. So this is the underfill theory. So where there is depleted intravascular volume, hypovolemia will affect. So in overfill theory, what happens is there will be exaggerated RAAS activation. there will be more renin, angiotensin, aldosterone activation. So what will happen is the rate of fluid shift from intravascular into extravascular as compared to the activation of RAS is not comparable. So maknanya there will be more salt and water retention as compared to fluid shift from intravascular to extravascular. So what happened is the volume will be hypervolumic. There will be hypervolemia. So bila hypervolemia maknanya apa? There will be no tachycardia. Your heart rate will not change. Blood pressure will remain stable. If you look at the IVC, the size of the IVC, the lumen of the IVC will remain stable. So this is when your this is overfill theory. So this is why sometimes nephrotic syndrome you may find that the blood pressure remains normal and so on and so forth. Okay, faham? Dapat tak pathophysio dia? Because if you understand the pathophysiology, then you can understand the treatment modality. Okay, faham? Faham ke tak faham? Tak faham je. Tak ingat? Am I confusing you all? Okay, last. It's already 1.5 hours. This is not ideal. Okay, last. How about AGN? How is it compared to AGN? Pathophysio. What happens in AGN? Rauda, kita start dengan Rauda dulu.
Ya, doktor.
AGN. Pathophysio of AGN. Cepat. Pathophysio of AGN. Apa yang happen?
There will be inflammation and proliferation of glomerular tissue and result in damage to the basement membrane, mesangium, and also capillary endothelium.
Lepas tu? Izati lah. Lama dah tak tanya Izati.
Yes, doktor.
Cepat.
Acute glomerulonephritis is due to glomerular lesion that results of deposition or in situ formation of immune complex. So this immune complex will
Baca mana Google tu.
Yes, doktor.
Masalah tu. Okay lah, fine. Stop googling. You can Google much more after this session. After this session kita discuss lah. If you don't know then say I don't remember.
I don't remember.
Kita boleh discuss lah. You can Google after this. I'll give you ample time to you'll have 3 years to Google.
Okay.
Lampau budak-budak ni.
Sorry.
Ifat, nak offer jawapan?
Not really, but from what I understand, it is due to the immune response towards the glomerular wall. Then this will cause glomerular damage, and then it is permeable also for the components of the plasma to get through the fluid, and then this will cause hematuria.
Okay lah. Dia macam ni ya. Okay. So I'm gonna give you certain keywords that are important because you know nephrotic syndrome is a favorite question to ask in exam. It's very easy. Your exam will be modified long case kan? Your block exam is modified long case, which I don't like. Your block exam will be man or ski. Manowski punya style. Kan, so Manowski will call patient from home. So among the cases that we always call from home are nephrotic syndrome, because we have so many patients with nephrotic syndrome. We have the list of them. They can come anytime. They used to come in exam. Some of them comes in every professional exam. We will call several cases of nephrotic syndrome. So nephrotic syndrome are the typical exam cases. That is why you need to know what is nephrotic syndrome. And nephrotic syndrome AGN are also favorite questions in theory because it's very easy to ask. I can make the question without even looking at book. You give me, if I were to ask, Syed, I give you 10 minutes to make question, exam question. The easiest that I can come up is nephrotic syndrome AGN because it's basic. So it's a basic. So we need, it always come up in exam. So you need to know. Okay, fine. I'm just going to give you briefly what is the pathophysiology. So basically, AGN mostly is caused by post-streptococcal infection. And we know which type of streptococcus. This is group A beta hemolytic streptococcus, such as Streptococcus pyogenes, for example. Kan, basically group A beta hemolytic streptococcus. And this group A beta hemolytic streptococcus, what is peculiar with them is that they have capability of molecular mimicry. So their antigen may mimic some of our molecules of our body, such as dia ada yang this group A beta hemolytic streptococcus ni, dia ada nephrogenic strain yang can result in AGN. Dia ada cardiogenic strain that may result in rheumatic carditis. Kan? So there are two types of strain. So sebab itu you won't get both nephrotic and carditis. You dapat salah satu je. The God is not as kejam as tu lah, kan? Allah tak sekejam itu. Allah bagi satu je cukup. Satu pun dah cukup complicated dah, kan? So there is cardiogenic strain atau nephrogenic strain of streptococcus. So you may get this infection by macam mana you dapat streptococcus infection? Sore throat, ear infection, skin infection, you can get skin infection, impetigo, kan? So all this infection with streptococcus after 3 to 5 days. So your body will produce antibody against this streptococcus. Antibody will bind to that antigen. And what happens is your antibody complex ni, because of molecular mimicry, it will deposit on the molecule that dia mimic. So finally the antibody complex will deposit on your glomerular basement membrane. Bila dia deposit banyak-banyak dekat glomerular basement membrane, what happens is it will cause inflammatory cascade. It will activate inflammatory processes. Your complement activation, interleukins, TNF factors, all the inflammatory reactions will happen. And what it results in? It results in inflammation of your glomerulus, inflammation of your tubules, and so on and so forth. So this inflammation results in so many things. First, it results in hematuria. Hematuria, why? Because effect of your tubules, effects in your glomerulus too, they become more porous to certain things, such as your blood. That is why you may get gross hematuria, microscopic hematuria. And then because of the inflammation of your GBM as well, results in impaired GFR, impairment of your glomerular filtration rate. In nephrotic syndrome, your kidney function is not affected. Nephrotic syndrome, your kidney function remains intact. Your kidney can filter out, your urine output is not affected because urine output is still okay. Only because of RAAS lah. Kalau tak, your urine output, the kidney is still has good urine output. But with with AGN, it affects your glomerular filtration rate. GFR will reduce. Your urea will increase. Your creatinine will increase because of impaired renal function. And this results in oliguria, reduced urine output because of impaired glomerular filtration rate. So oliguria results in apa? Results in hypervolemia, results in reduced urine output, oliguria, results in water retention, and the result of that is increased plasma hydrostatic pressure. Increased plasma hydrostatic pressure, and then affects your stalling forces. So there will be fluid shift from intravascular into extravascular space. So that is why you have edema, but the edema is not as severe as nephrotic syndrome. You have hypertension. So the hallmark of nephrotic AGN is hematuria, edema, oliguria, hypertension. So these are hallmarks of AGN. Boleh differentiate tak between nephrotic syndrome and AGN? So they are the element cardiovascular effect in terms of blood pressure. Kalau nephrotic syndrome yang overfill, you boleh dapat high blood pressure as well, but not as high as AGN. Kalau overfill theory nephrotic syndrome, you can have oliguria as well because of RAAS activation. But in AGN, it is much more marked. And in nephrotic syndrome, you won't have hematuria. Unless kalau nephritic lah, which is another discussion. Itu nanti bila you dah jadi houseman, kita discuss satu-satu. Nephritic, where the patient have both component of nephrotic and also nephritic as well, with different pathophysiology. So you need to understand the pathophysiology. So if you understand the pathophysiology, baru you tahu what are the questions you need to ask. Baru you tahu how you're going to proceed with management of all the disease. Kenapa in nephrotic syndrome you tak bagi, you tak perlu water retention, you tak perlu fluid restriction. You only fluid restrict on cases with AGN. Nephrotic syndrome, you tak fluid restrict. Kenapa you nak fluid restrict? Dia dah underfill. Dia dah hypovolemia. Lepas tu you fluid restrict, what's going to happen? Matilah benda tu. Kan? Tapi kalau ada AGN, you tahu dah, dia is overfill, dia hypervolemia. So, what's going to happen? So yang tu you kena fluid restrict. Yang tu you kena reducekan. You tahu dia ada salt and water retention. Sebab tu you kena reduce salt intake. Dia ada oliguria. So you bagi diuretics. Ada blood pressure dia high. You control blood pressure. You bagi diuretics. You bagi calcium channel blocker. You bagi beta blockers. You bagi ACE inhibitor. You bagi angiotensin receptor blockers. So understand the pathophysiology. Okay, fine. This is already 1 hour 40 minutes. This is already way past what I prefer. That is just very brief of both pathophysiology. That's very brief. Okay. Any questions tak before we need to stop? Tak ada. Faham lah ke? Clear. Next time I tanya pasal nephrotic dengan AGN semua boleh jawab dengan pak macam tu je. There are certain keywords. If you remember, when I say something, keywords I always emphasize. It will be highlighted by a higher pitch in my voice and a slower pace of my speech. So those are keywords. So those keywords, remember those keywords. I expect those keywords to come out in exam. Okay, Aci. Aci mak labu lah. Okay. Alright, kalau tak ada soalan, faham lah ke semua power dah. Balik please baca nephrotic syndrome and AGN. Okay lah, you can Google. Tapi sebelum you Google, make sure you baca PITS protocol dulu. It is a sin to Google without baca PITS protocol dulu. Okay, you baca PITS protocol dulu. Lepas tu baru you Google. Kalau boleh, janganlah baca Google. Google tu banyak benda mengarut dalam tu. Kan? Nanti you alang-alang Google tu, you baca gosip lah apa semua benda kan. So, kalau boleh, medical student at least PITS protocol kena baca skin to skin because I make questions from PITS protocol. I don't care. Kan? Kalau you good students, go and read Nelson. If you are slightly good student, at least baca Tom Lisawa punya book. Tu buku yang basic lah, buku orang suka-suka baca. Ada banyak lagi buku lain. Tapi at least minimum reading for undergraduate is PITS protocol. That's the minimum reading for medical student. Okay. Alright. Yes, cukup lah. 1 hour 40 minutes. Okay. Let's end our session with Tas kafarah surah Al-As. Do I have any other sessions with you?
Rasanya tak ada dah.
Tak ada dah sampai exam.
Itu tak pasti.
Yeah. Make sure you can arrange another session with me. We can discuss about pathophysiology of the sounds that you hear on respiratory examination. Pathophysiology of the sounds that you hear on cardiovascular examination. Don't do it one day before exam.
No.
Okay. All right. Fine. Okay. Assalamualaikum.
Thank you, Doctor.
Thank you, Doctor.